Well, let's get started, and thanks everybody for joining. And if you're able to go on video, great, so we can see your smiling faces. If not, no problem. I know people are joining from a variety of places. Just for introductions, for those who don't know me, I'm Michael Goldberg. I'm our executive director of the Veale Institute for Entrepreneurship and a professor at Weatherhead. And we're thrilled to partner with our friends at the School of Medicine with the Innovations Pathway, Dr. Mahmoud Ghannoum and Dr. Joe Jankowski, as part of our Pathway series and Entrepreneurship Speaker Series. And it's great, Julie, that you're able to make the time to join us from South Dakota as you renovate a house, and it was great catching up a little bit on that. All of these sessions are moderated by students, and we're thrilled that Clara's son, who Julie got to meet briefly, who's a second-year School of Medicine student, is a student that I know well because we're working together on a new alumni venture fund. She had some experience as an undergrad at the University of Miami. So Clara's going to run the show. We love these to be interactive. So I know she's got some questions, and then want to hear from everybody on here. So just let Clara know by raising your Zoom hand or real hand, or put a note in the chat. But with that, Julie, thank you for joining. And Clara, I'll turn it over to you.
Thank you.
Yeah, sounds good. Really great to see so many people on here. 28, I'm sure more people are streaming on LinkedIn. So thank you all for coming, and really great to have you here, Dr. Gerberding. So as Professor Goldberg said, I'm a second-year med student here at CASE who will be moderating. And I was thinking with the hour time that we have, I'll just ask a few of the questions that I have already written for the first 30 minutes or so. And then the last 30 minutes, open it up Q&A for all of you audience members, and feel free to turn your camera on and unmute yourself and ask your question. So I'll just start with a brief bio of Dr. Gerberding, just for anyone who doesn't know. So Dr. Julie Gerberding is Executive Vice President and Chief Patient Officer at Merck, where she is responsible for patient engagement, corporate social responsibility, ESG, and other functions. Formerly, Dr. Gerberding oversaw Merck's communications and global public policy functions, and she joined the company in 2010 as president of vaccines and was instrumental in increasing access to Merck's vaccines to people around the world. And Dr. Gerberding recently announced she will retire from Merck in May of this year and join the Foundation for the NIH as their chief executive officer. And previously, Dr. Gerberding was director of the US CDC, where she led the agency through SARS and over 40 emergency responses to public health crisis. And she served on the boards of Cerner Corporation and MSD Wellcome Trust Laboratories. And she also co-chairs the CSIS Commission on Strengthening America's Health Security. And lastly, Dr. Gerberding received her undergrad and MD degree from Case Western Reserve University and Masters of Public Health at the University of California, Berkeley, and she completed her internship and residency in IM and fellowship in clinical pharmacology and infectious diseases at the University of California, San Francisco, where she is currently an adjunct associate professor of medicine. So very long, impressive bio, but again, it's great to have you here, Dr. Gerberding.
Well, thank you. It's my pleasure and my joy to really have a chance to chat a bit. And I look forward to questions and comments and conversation.
Yeah, definitely. And from that very impressive, extensive bio, I think my first set of questions is more career advice, and then maybe some other questions about your views on our healthcare system and the work that you do with Merck. But just to start off, like my initial thought is kind of how you jumped from, medical training, finishing residency, and then to the president of or heading the CDC. So would you be able to help us like fill in the gap there of how, your career?
Yeah, so I would love to be able to explain to you that this was all part of a plan and that I carefully executed it over the years of my career, but actually it wasn't. I knew from age 4 that I wanted to be a doctor, from 7th grade that I wanted to go to Western Reserve School of Medicine, which then became Case Western Reserve. So that part was a plan, and I was lucky to be able to fulfill that aspect of my dreams. But once I got into my training at UCSF, I recognized that as AIDS was starting at the same time that I was an intern and all my patients were dying, that there was a lot more to medicine than what we could do at the bedside. because in those days we had no treatment. So we could manage the opportunistic infections, but basically every hospitalized patient was doomed to die in the not distant future, because by the time they had hospitalized opportunistic infections, they were profoundly immunosuppressed. And the patients were, a wide and diverse group of people, but they did have in common the fact that much of what determined their health, their well-being, their social support, and their ability to manage the complications of their illness depended on things that had very little to do with what doctors were prescribing and a lot more to do with what was going on in the community. So I kind of got hit straight on with the social determinants of health, the importance of stigma. I mean, it was, if you think about it, AIDS is a disease that really brings together the things that traumatize people the most or cause the most psychological anxiety. It's about sexuality, it's about morality, it's about mortality. And when you have those things kind of incubating in a cauldron on top of day-to-day issues, it's impossible not really to make the connection from the bed to the bench in the pursuit of medicines and treatments, but then, to the beyond, into the community where you really can't treat a patient if you don't know the beyond. So that started my transition, and I won't go into all the details about what prompted me to get my MPH, et cetera, but I found myself as a young, aiming for tenure faculty member, having a lot of duties as assigned in the hospital. And I kept aggregating. I had the HIV counseling and testing service. I ran the occupational needle stick hotline and some post-exposure prophylaxis protocols, et cetera, et cetera. And somewhere along the line, I became the hospital epidemiologist, and that caused interest at the CDC. So they initially recruited me to go to CDC to run the division there that was responsible for nosocomial infections and healthcare quality. And I was certainly, at that time I had tenure, and I was not really eager to give up my tenure position. So what I did was ask for a leave of absence. And, I literally did go to the dean and say, these are the top 10 reasons why you should allow me to have a leave of absence. One of them was that you let Dr. Harold Varmus have a leave of absence when he went to direct the NIH. And the dean responded to me by saying, yes, but Julie, please do keep in mind that Dr. Varmus has a Nobel Prize. You do not. But at any rate, I was not intending to be in public health. I just felt like it was a good opportunity to serve my country and learn something new and get a new stretch assignment. And after I was at the CDC in that role, I coincidentally was just asked to be the acting director of the National Center for Infectious Disease while they searched for the right person. 9/11 happened, anthrax happened, and for reasons that I may never fully understand, I was asked to assume the role of the director. And so that's pretty much how that happened. And when my time at CDC ended, my mentor from Case Western, Dr. Adil Mahmood, who had by this time retired from Case and had been the president of Merck Vaccines until he had to retire at Merck at age 65. He contacted me and said, guess what? I know your next job. You're going to Merck. You will be the president of Merck Vaccines. And I said, I'm certainly not working for a pharmaceutical company. And he said, well, just come on out here and take a look at the job. And what happened there was the CEO at that time, Dick Clark, and the soon-to-be CEO, Ken Frazier, really talked to me about how their vision was to globalize vaccines, that Merck's vaccines were mainly used in the United States and Europe, but many of them were important for global health. And with the right leader and the right team, we could manufacture more doses, and we ought to be able to find a way to bring these vaccines to the rest of the world. So long story short, that was a chance to make a tremendous difference, particularly for HPV-related cancers, and I signed up. So that in a nutshell is, a kind of a fortuitous chronology of how I jumped from one sector to another. But in my heart, I think the thing that has always been the connector of whatever job I happen to have at the moment is a really incredible commitment to patients and an incredible belief that to really create healthier patients requires not just the medicine, but it requires the surround sound of their support system in their community.
Yeah, definitely. Thank you for a wonderful answer and filling in that gap. And I think your answer already hit on a number of other questions that I was thinking about, is kind of how you jumped from, one big position to a next. Like, you already you're comfortable in that position, you're tenured professor, etc. So kind of like, what questions you ask yourself before that next decision or big career decision? And kind of like the thread that connects everything is just your commitment to patients, public health, like seeing another opportunity to better serve patients at a broader scale. So that's very inspiring to hear, for sure. And I think something that a question that recently came to me, and that I've been talking about with a number of other medical students, is that having your interests outside of just clinical medicine is super important, and kind of the work that we're all doing here as med students. Part of this innovation pathway is that we're all, in addition to clinical medicine, seeing patients, we're interested in policy, entrepreneurship, venture capital, and figuring out ways to integrate all of these external business interests into adding more value to clinical medicine. However, I think sometimes students aren't always recognized that it's a positive thing. For example, students who maybe are more inclined for business endeavors go unmatched because they are seen as, maybe their business interest is going to mean that they might leave residency in the future, or it doesn't show their commitment to the field. However, there can be ways to integrate both and be able to make a broader impact for a patient. So I guess that's a long-winded question, but I guess I'd love to know your thought on that, and maybe how to combat for medical students who are interested in, bigger ways to make an impact for patients outside of just clinical medicine. Like, what is there a way to combat the stigma that current, healthcare providers might have?
Well, this kind of stigma is common no matter where you are in your career. So, if you're a research investigator, some people will think that you are not a real doctor because you're not at the bedside. Or if you're a real doctor at the bedside, so to speak, then people in the research community might think that, you're just a translator and not really creating knowledge. So it isn't limited to the business clinical medicine dichotomy. It's just, in a sense, another manifestation of what color is the grass on the other side of the fence. So, I don't really let those things bother me, because you can always go into another pasture, as I think my career has proven, going from academia to government to private sector. I've been in nonprofit global health organizations as a board member as well. And I sit on the boards of a couple of companies, and now I'm going into an important foundation whose major focus is building private-public partnerships to do things that companies or government cannot do alone. So, it's easy for me to say, because I'm confident that such transitions are relevant and there are lots of different ways to contribute. I wouldn't worry too much about the stigma. When people demonstrate success and achievement, kind of stigma fades into the background. So you can earn your way out of it for sure. And just go for it. And the other thing, I think people feel like they're making a life and death choice. You're not. You can do one thing and then you do another thing. The most valuable people today are people who have lots of tools in their toolboxes. Given the complete chaos in the world in which we live, including the chaos in the job market, the most valuable people at Merck are people who can do more than one thing, or who have participated in more than one kind of environment. Because if suddenly the bottom drops off of one avenue of entrepreneurial work, you have the ability to open the next door and walk through it. And folks who are very siloed and very focused sometimes really struggle with that.
Mm-hmm. Yeah, thank you for that answer. It's very, very reassuring, for sure. And another question is what are some personal challenges that you might have faced along your career that had a big impact on your professional journey, but how did you overcome that?
Well, thank you for asking the question that way. I mean, usually I'm asked about gender issues, and yeah, I would be lying if I said I didn't occasionally have such issues. That would be, disingenuous of me. But I think the challenges that I've had along the way had more to do with maturation of my leadership competencies and maintaining the opportunity to continue to learn and take input and feedback and grow and evolve.
About Annie's funeral on Saturday. Her funeral, of course, is Saturday at 10.
Someone is
Someone had sadness. I think I lost my train of thought there for a second.
You were talking about your maintaining your leadership.
Yeah, learning and recognizing, I mean, very early on, when I transitioned from being a chief resident to being an attending physician at the bedside for the first time, I remember, overhearing my residents say, well, she's really bright, but she's in our way. She's always, she thinks she's the intern. And I'm so glad I overheard that, because he was absolutely right. I hadn't figured out how to lead a team rather than do the work. And so I had a great chat with the resident, and he really helped me see how I was in his way. And it would be so much better for his learning if I would step back and be the coach and not the doer, et cetera, et cetera. So, that kind of openness to being able to see how you can improve and grow is part of my professional philosophy. It's not easy, and it does create challenges, but I use this description probably too often, but because I am an infectious disease doctor, I'm very interested in bacteria. I studied them in the lab. They grow logarithmically, 2, 4, 8, 16, 32, 64. And when they run out of media or space, they go into stationary phase where they just hang out and don't accomplish too much. And if you don't either feed them or put them in a bigger beaker, they die. And I think that's kind of how I think about my professional development. I love to be in log phase when I'm learning and growing and feeling the challenges and struggling to solve them. I'm the happiest. But when I'm sort of coasting or things are just kind of going along the way they always have, that's stationary phase. And to me, that's the harbinger of bad things to come. So that's kind of why I find it not impossible to make a career move or to learn a new skill or take on a new challenge. And you don't have to get a new job in order to stay in log phase. Sometimes it's just having a new experience or taking on a new responsibility. But it is important not to let that complacency of the stationary phase creep up on you, because that's when people, it's like being burned out. You just really aren't at your best. You don't feel good inside. And when I find myself falling into that state of affairs, I know, I think it's time. I'm going to have to get a new 5-year plan here and think about what I need to do to stay in log phase.
Yeah, thank you. I love that analogy. And especially when you're talking about working with a resident to improve and see kind of how you can work on just improve from a different angle. I feel like a lot of case students here resonate with that, because case med school loves feedback, and we always have to input feedback about our classmates, ways to improve, stuff like that. So, but it's really important to be able to, really take in and listen to what other people have to say, even though it's might be difficult, but that's a really important part of growth. So thanks for sharing that. And another question I have, more related to not about your career, but just about healthcare in general, about the pandemic, is what are lessons that we could take away from the COVID-19 pandemic and to ensure that we're prepared for future emerging infectious diseases?
Well, this could be a grand rounds presentation.
Yeah.
So I will really have to be abbreviated here because there's so much we need to learn. But maybe one of the overarching lessons is that we are in an era where biosecurity threats are going to be harder, more frequent, and more deleterious to individuals in our society, because every force is pointing in that direction. Climate change, social disruption, urbanization and incursion into previous sylvatic areas, spillovers from animals to humans, disruption in the normal ecosystem of vectors and the interaction of humans and animals, the One Health complexities, the incredible connectivity of our world, the air travel, the cruise travel, the international airports, ecotourism. I could go on and on and on, but everything in our world is creating the environment. And then on top of that, let's think about what's going on in the Ukraine right now. Think about those 64 million forcibly displaced people in the world and the conditions that they are living under. And I think we'd be crazy not to think that either Mother Nature or human intent is going to continue to create important transmissible infectious disease threats. And those aren't the only threats, but those are the threats that, COVID certainly brings to mind. And so we do not have an approach to biosecurity that reflects the severity and the potential problem that we are facing. We do have such an investment in nuclear threats and other more Defense Department threats, but for some reason, we just have had trouble imagining how bad a global pandemic could be in 2020 and beyond. And so our investments have been scant, scattered, and ultimately inconsistently sustained. So the commission that I co-chair, the Commission on Global Health Security, really has titled its first report, which came out before the pandemic, ending the cycle of crisis to complacency. Because something bad happens, we spend a lot of emergency money, we race around, we try to solve it quickly, and then the money goes away and the interest goes away, and we just revert back to our sort of stationary phase. And I think that's the biggest lesson overall, that we need a long-term consistent strategy of improving our overall biosecurity that takes into account the fact that we live in a global world, we live in a One Health world, and we do not really face our problems with that mindset. We face them as, oh, this health issue popped up. Isn't that frightening and unusual? Let's get rid of it. Now we can go back to the way things were. This is not going to be a smart strategy going forward. And I think the other thing about COVID that really stands out for me is that we do not live in a society that handles scientific ambiguity. I'm not even talking about intentional disinformation, but I'm talking about what happens when people are confused because they don't have the fundamental skills to understand what's going on. And then they get all kinds of chatter from people who think they're experts. Have you noticed there is actually a pandemic of coronavirus experts that seems to be asticizing widely? So when you don't really have the ability to make that kind of scientific judgment yourself, you really do rely on the people you trust. And these days, the people you trust the most are the people you know the best. And those are usually your friends in your local community or your social media contacts. And often they don't know any more about what's going on than you do. So you get into these echo chambers, and that is probably not going to change. So we're going to have to figure out as leaders and as scientists, how are we going to accept that power of those approaches and really help build a more scientific literate society, but also translate science in better ways so that people can take it in and respond to it and make good decisions. There's a lot of shortcuts that people have talked about to try to improve this, and particularly in the communication domain. But communication is not unidirectional. You could have the best communicator in the world, but you still need a receptor at the other end. And I think we have both a synaptic gap in both directions, shall we say.
Yeah, definitely. I think you touched on a lot of great points there, and even offering ways that we can work to address that science ambiguity and with how we address natural disasters or things that come up instead of and thinking more about the long term and ways to that students can definitely think about now to work towards. So thank you for that answer. And yeah, now with about 30 minutes left, I'd like to open it up for Q&A from the audience. So feel free to turn on your camera and unmute if you have a question that you'd like to ask Dr. Gerberding.
And please call me Julie, by the way.
Okay.
Maybe while people are thinking, I want to bring up 2 points which you raised, which I really loved, by the way. Number one, as a microbiologist, the log phase is, I loved it because it is very clear to me. But what's really more important in that analysis, which you touched upon, is that you really, like, if there's any advice that the student should take is you are all the time need to be moving. You are all the time need. So I give you an example. When I was at UCLA before over 25 years ago, I was working on phospholipase, virulence factors of Candida, which make it more pathogenic. And then I got funding from NIH, and after this, I knew, like, once you clone the gene, you show what it is, and I knew that is gonna finish. So I start thinking, okay, what am I gonna do next? And then I go to a meeting and people talking about biofilms. Oh, biofilms, that's very nice. And since I would call myself a fungi because I work with fungus. So I said, okay, let me work with the fungal biofilm. And of course, that attracted a lot of funding and publications and so on and so forth. And then just before that, and the finish of the biofilm story, I heard about the microbiome. And everybody's talking about bacteria. I said, no, you have to work on fungus. So the point which I am bringing is, for students, you should not stay in something and stationary, because all the time you need to build. So your message is, go out of this silo, try to find new stuff. I love that. I really love that. And I think this is gonna, I hope the students, they got it, and that's gonna help them. So,
one of the reason I wanted to go to Case Western Medical School when I was in 7th grade is because I read a book called So You Want to Be a Doctor, and it described the curriculum of the integrated learning, the cardiovascular system, the neurologic system, so that, cross-disciplinary approach to learning medicine just intrinsically, for whatever reason, appealed to me. But that framework that we learn at CWRU has been the framework of my whole career. My first, as I told you, when I started as a junior faculty member, I just kept getting all these pieces of responsibility that didn't really fit together. But then we said, well, what do all of these pieces have in common? This is all about nosocomial and occupational infectious diseases. Let's build a prevention epicenter and figure out how to study and prevent occupational nosocomial infections in healthcare settings. Fast forward my time at CDC, I had many centers. They never worked with each other. And we had a center of environmental health that arguably has the best NMR capacity of any institution in the world, that exquisite technical capability, a whole building full of machinery. And they can measure the conformation of botulinum toxin to distinguish the various types of botulism, which at that time was very important because we were concerned about bioterrorism. Meanwhile, over in the Infectious Disease Center, they were determining botulism exposure by inoculating mice to see if they lived or died. These people never talked to each other. And in the same institution, we had this advanced competency, and we had the tried and true traditional public health methodology, but because they were not integrated in a horizontal way. So that became something I worked really hard on at CDC. It didn't go too well because many people like to be in their vertical domain. But when I went to Merck, it was exactly the same challenge. The people in manufacturing hated the people in commercial because the commercial people weren't selling enough, the people in manufacturing weren't making enough, and the people in research were too slow in pulling things through the pipeline. So they were always at each other's throats. And we brought everybody together and said, we're one. vaccine business. And when we work together, we'll be stronger. And sure enough, we turned that business around and we were able to globalize our products. So I think the lesson here is that, yes, you have to change and grow as things evolve, but don't think you have to do it all yourself. Often the best way to get hard problems solved is to take advantage of the wise crowd. And to me, that's really one of the terrific things about the Veale, that, you know, you've got a wise crowd of faculty members that have wisdom in so many different directions. And you've got a wise crowd of incredibly innovative students. You have the Think Box with everything that brings together. It's a candy store for connectivity. And it's on the edge of those boundaries where the most creativity comes about. So don't be afraid to reach out and connect with someone who may be doing something slightly different. You'd be surprised what you can learn and discover in those boundary states.
Yeah, and proximity, it does not, it's needed, but not enough. When we started the culture program 15 years ago at Case, one of our strengths, of course, was that our biomedical engineering department was, you know, literally, for those of you golf, maybe a 3-wood across the street from university hospitals. And after our first year, the first RFPs, we surveyed faculty in BME to see what they thought of it. And the biggest complaint was, we don't know any doctors. And people just assumed on the other side, of course you'll know doctors, you guys are in the same, you know, same block, yeah. But you have to be open to that. Hey, Julie, I want to take the positives of interacting with one of the negatives you talked about earlier that really was highlighted during the pandemic, which is misinformation. We've found that scientists and doctors are totally mission oriented and are, you know, absolutely love communicating outcomes, but usually within their peer group, right? So we have peer reviewed activities. And I know 10 years ago when some of the misinformation around climate change was coming out, you know, us on the know, right? The educated folk were like, this is crazy that people are out there saying these ridiculous lies. But then somebody said, well, what do you guys do to go talk to the public? You as a doctor, as a clinician, you know, do you go and speak to the public about these things? And usually the answer is no. It's like, I'd rather stay with my own, you know, pack of educated people. I don't want to engage. So we allow the non, you know, educated voice to really at times manipulate the society. So I don't have a necessarily easy thing other than your question, other than to say, has this recent, you know, spike of misinformation on COVID at Merck's level or at the government level, are things going to change? Or are we going to support, you know, scientists and clinicians more in their early stages to help them realize this is part of the job too, that it's not just enough to have great discoveries in a lab, but you need to be able to communicate that to society? Or do you think we're going to just keep this cycle until, you know, hopefully somebody fixes it?
No, I hope we don't. I mean, I hope we don't just keep the same old. I think the imperative is to recognize that no matter what profession you're in, but certainly if you're in the medical profession, communication is as important as what you know about a diagnosis or a medicine. When I used to have to do, I'm an introvert, by the way, so it takes energy for me to speak to people or do a hearing or a press conference. And when I was at CDC managing a bunch of different kind of hot topic outbreak type situations, including SARS, I had to do a lot of press briefings myself at CDC. And I really found that the best way for me to be an effective communicator in those circumstances, aside from like actually getting training and practice and watch those embarrassing moments that didn't go well and learn from them, was to just find one person in the room that I would imagine in my head was my patient. And I would be explaining what is going on to that person in the same way that I would be explaining some difficult news to a patient at the bedside, with a minimum medical jargon, and, you know, certainly didn't use PowerPoints or charts, really introducing the human caring element of bedside manner. And that for me seemed to be as important as what I said. We certainly didn't have a perfect track record of communication, but I think that fact that people who care need to be part of the channel of messaging, especially when times are frightening or challenging. And who learns that better than people who are in the healthcare professions? So we have a special responsibility to be part of that messaging. But it is also, you're not born with it. Some gifted people are, I'm sure, but generally you have to learn and practice and apply. And I think it should be a required part of the curriculum. We do have that, you know, in terms of patient engagement, but I think just extending that out to beyond the patient is something that would be a really important add-on for most people, even if you don't end up in public health or public policy or being a spokesperson. In almost every role that you will have, communicating something difficult to others will be a part of it, and learning how to do that comfortably and responsively is I think an essential skill set. But the other point I'll just make very quickly is that when you really study, for example, the anti-vaccine conversations that go on in social media, the people perpetuating those conversations are very small in number. There are a lot more of us than there are of them, but we don't participate in the conversation. But every once in a while, there is a committed activist clinician. There's one in Italy, for example, who has just an enormous following of people who stand strong on the science and the public health value, and he is a powerful force of persuasion for parents in Italy. So, you know, sometimes we think somebody else will do that for us, when actually, if all of us just communicated a little bit more, we would be a very powerful force of a different conversation.
Yeah, thank you for that answer. And it looks like we have two people with their hands raised for questions. So I'll have Scott introduce himself and ask his question.
Thanks for the great talk, Dr. Gerberding. I'm a first-year medical student and a machine learning engineer interested in software entrepreneurship for healthcare applications. And I think, like many of the other people here with future entrepreneurship aspirations in the healthcare field, that will involve some degree of conversations with the government, different government agencies, getting the government to understand our mission, why whatever we're developing could be applicable and beneficial to patients ultimately, and safe and effective. And so I think your unique perspective as someone who has been both in government and industry and innovation might allow us to learn a little bit from you about what constitutes like a productive relationship, or how someone might go about cultivating a productive relationship between industry and government, and where strengths can happen there, as well as where communication can break down and innovation might be stalled because of a lack of a productive relationship. So I would just ask for your perspective on that, maybe an anecdote or something that you've seen where things have gone well versus not well between industry and government, and how you facilitated productive relationships between industry and government in your own work.
Well, when I was in government, the Congress was a little less partisan than it is now, but not much. And when I went to the company, I tried to avoid government engagement when I was initially in vaccines, just because part of the reason I left government is I didn't want to be involved in that. But when I took on the policy responsibility for the company, I had to re-engage. And I think the thing that I believe, and I say this not just about the US government engagement, but also all over the world. I've been with the government in China and Taiwan and in European countries, et cetera, is that if you go into a conversation with government officials hoping that they will help you solve your problem, you will not be successful. The best way to engage with the government is to understand what this individual or this party or this government is trying to accomplish, and then really think, how can we help them solve their problem? Because if you bring solutions, then you have something to talk about. And I'll just give you a very specific example that wasn't done by design, but turned out to be incredibly valuable for some of my teammates. And that is a very passionate man on my team, Boris, just was so upset about the plight and the poor, deplorable health conditions of homeless people in Europe that he established really almost by himself, working with a number of existing NGOs that service some part of the homeless community, an entity, I think in English, it's no one left outside, which basically means no one should go without healthcare. And, you know, he didn't do that at the time, recognizing that the politicians really cared about homelessness. But if you're a politician running for office and you have a bunch of homeless people that are visible in your community, you have a problem. And this program has now been activated in most countries in Europe, and the homeless populations are very different. Some are refugees, some are migrants, et cetera, et cetera. But when Boris goes in to talk to the government, he goes and talks to them about their homeless problem and how these organizations are coming together and what they need to solve the problem. So you can imagine that then the next time Boris has an issue, the door is open to him. He has built trust and a relationship with people who recognize that he has something to help a broader set of social circumstances, and he's a valuable member of the team. That approach is one that, Merck is not the only company or the only entity who does things that way, but I think what I see even inside of Merck, I am sometimes in the room and I'm appalled when, you know, I've worked for a long time to have a special relationship with members of a particular government, I won't say which one, and I have most favored nation status with this government. But I once went in there with one of our commercial people who just immediately launched into the justification about why our drugs should be approved and, you know, how blah blah blah, and you know, that was just terrible, because that's certainly not how I approach senior policy engagement. And it's so easy to get caught up in your own issues without really recognizing that the best solutions come when you really have deep understanding of what the government's trying to accomplish. Now, if you're working with a government where you don't agree with what they want to accomplish, that's a very different story. So tactics are different in that case. But I think the other aspect of it is to join forces, to move the conversation beyond the parochial concerns or perspectives that you might have, and to learn and engage with a broader set of allies. And often that creates new policy opportunities or ideas you might not have thought about, but it also creates a more powerful engagement strategy, because then you have many voices and new perspectives, and our congressional leaders learn from that sometimes.
Yeah, that's really good advice, to not only go in saying, this is my problem that I want to fix, but also saying, how can I help you fix your problem?
Yeah, exactly.
And then you can build an alliance from there to move forward. That's really valuable advice. Thank you.
Amazing. So we'll go to the next person with their hand raised. Allie, feel free to unmute yourself and ask.
Dr. Gerberding, thanks again for speaking with us today. It's really quite an honor to hear from you. I am a second-year medical student, and I noticed a couple of things during your talk that I had follow-up questions on your introduction. You talked a lot about your own personal leadership growth throughout your career and how that continues to be a point of growth for you. Do you have any specific recommendations for how to improve your leadership skills at this level in the game as a medical student, as a trainee? Specifically, are there any opportunities that you took or wish you had taken looking back that made your leadership skills stronger?
As I said at the beginning, I'm in South Dakota right now in the basement of a house that my great-grandfather built. But the reason I'm attached to this house and I'm trying to restore it is because my grandmother lived here, and she was the executive director of the Girl Scouts in our state. And she hired me in the summers to be a camp counselor. And believe it or not, that's probably the best leadership training I've ever had, because, you know, I went from being a very, very shy girl to being, you know, the person who had to lead the songs at the campfire, among other things. But I'm not really being tongue-in-cheek. I think sometimes you learn leadership by watching people who are really good at it, or people you admire, and trying to ask yourself, what is it that makes this person effective as a leader, as my grandmother certainly was. And I also think the part of that is the experiential learning. I mean, I just got thrown into the job. No one sat down with me and said, no, this is how you are a camp counselor. And this is, the way you should do X, Y, or Z. You learn by, intuiting what's working and what isn't working. But in my later career development, I've also learned, I think, a more mature understanding of situational leadership. When I was starting my research career at UCSF, it was a startup. My first office was in a patient's old bathroom. There was a bathtub in my office. And from there, that startup, I started with one staff member. And by the time I left, I had extremely good funding and many fellows and, employees, et cetera. So I built a research center, basically. And then I went to the CDC, and both jobs there really were crisis oriented. So that's crisis leadership, which, I wasn't completely prepared for, but, you had to learn as you go. Then I came to Merck, and I had to lead a turnaround because the vaccine business wasn't doing well when I got there, and we had to reorient it and globalize it. So that required a different kind of set of skills. And now I'm going to this wonderful foundation for the NIH that is not broken, that's actually growing, is the part of our world that really prosecuted the COVID vaccine trials through ACTIV and the antiviral and diagnostic studies that the US government supported with the NIH and the private sector. And so now I'm just going to be leading an organization that's in expansion and growth phase. Each one of those kinds of prototype situations does require a different kind of approach and skill set. And you don't have a roadmap to tell you exactly what to do. But to me, the best way I tried to improve my leadership is by getting feedback, which we've already discussed, but also by really analyzing the people that I think are particularly effective, and especially particularly effective in whatever kind of leadership situation I find myself in. So I'm still a work in progress, by the way.
Yeah, that was a great question, Ali, very relevant to being med students currently. And with 9 minutes left, I'd love to try to get through the next 4 audience members' questions.
Okay, so I'll answer short answers. I got it.
No, we'll go with Galen.
Yeah, thank you so much for speaking with us. This question is sort of directed towards your infectious disease background. With so many large pharmaceutical companies having kind of divested themselves from antibiotic research, I'm curious if there are particular policy interventions or trends that you see that you find encouraging, or sort of that inspire optimism in you in terms of combating what looks to potentially be like a significant challenge with antimicrobial resistance in the future.
Well, there are 2 problems that we have to address. One is science, meaning we need new targets and new approaches. And the second problem is the market, which is broken for anti-infectives. And we have to solve both of these. With the former, and because you're entrepreneurial in spirit, I will say a couple things quickly. Our general philosophy of anti-infectives, at least antibacterials, has been something I learned at Case. There's no killing if it's not a cillin, meaning we should try to kill the bacteria. We want bactericidal drugs. And of course, the specificity of that is lacking. And so we're killing everything, which means the biome is changed and we have all of the complications and problems and the emergence of multi-drug resistance. It doesn't seem like we should be perpetuating that strategy. So perhaps we need, instead of bombs, we need a more laser-like approach, would be to think about adherence or virulence factors, or, how can we detonate or de-detonate, I guess is the concept of the pathogenesis. With respect to the market, we're trying everything. We're trying push and pull mechanisms, and they're not working. Right now, the industry has said, okay, let's put skin in the game in a visible way. So I think Merck has pledged 100 million, and many other companies are doing the same. So we have a little more than $1 billion plus what Wellcome Trust has put in and the bank in Europe to try to do the discovery work, to get started, to fund entrepreneurial anti-infective research, to get more in the early pipeline, because the investors have backed out. They invested, but when there's no market for your invention, then the investors aren't interested in pursuing it. So we're trying to do our part, but at the end of the day, we still need a market, and either the market is the government decides to procure antibiotics on, on a kind of stockpile basis or a subscription basis, something like that, or we find a reimbursement mechanism that guarantees a fair return on the investment and the risk that's taken in developing them. And honestly, I've been working on this for more than 15 years and we have not really solved it yet. So it's still, and when the whole story of this pandemic is described, I think we're going to find out that multi-drug resistant bacteria had a significant vector of mortality that has not yet really totally been accounted for. But I don't think that it's going to be easy to convince people that if only we had better antibiotics, we would have had a lower fatality from COVID. It just always gets lost. And part of it is that, if you get cancer, there's a constituency of survivors who help spread the word of how important the newest treatments are. But if you get a drug-resistant bacterial infection, there's no community or, there's no constituency of people who are helping to carry the water on what needs to be done from a policy perspective to fix it.
Yeah, another great question. All right, we'll go with Chip.
All right. Thank you, Dr. Gerberding. I'm Chip Miller, and I'm a third-year biomedical engineer student here at Case, and I'm currently in a startup out of the Sears Think Box. And we're currently developing a microplastic filter to remove microplastics from washing machine emissions. And as a biomedical engineer, I became particularly interested in how microplastics can affect our health long-term. And as I did some research, I couldn't really find very much on what the long-term effects are. And my question is, do you know if there's anything currently going on regarding how the ingestion of microplastics is going to affect us long-term and like possible diseases related to that? And is this something that people are talking about, or is it something not so much people are talking about?
Well, I don't know the answer to your question, but where I would go to try to find the answer is to the National Center of Environmental Health at the CDC, because they are the brain trust of the monitoring of all things that are in our bodies that aren't supposed to be there. Everything from tobacco to phthalates to, the hormones in the water, et cetera, et cetera. So that would be the place that would be most likely, in my mind, to have the kind of data and the focus that you're exploring. So, we could start with their website. There's a guy there, I think he's still there, named Jim Pirkle, Pirkle. And he's a genius, in my opinion. And he would probably know if anyone would.
Great, thank you so much.
All right, let's try to fit in one more question with the 3 minutes we have left. Susan?
Hi, so first of all, to all the students, I put in the chat a link. Dr. Gerberding gave an incredible lecture last fall at the medical school, the society lecture, and it was extremely heartfelt and extremely inspirational. So I put the link in the chat, and I hope you all check it out. But I wanted to say that as a researcher, what I find so difficult is that really very little of our discoveries are actually implemented in public health and out in the community. And I'm from a very rural area, and that's especially true as you get away from the large academic medical centers. And I think it's a complex problem that, you alluded to a lot of the factors involved, but we don't do a very good job of trying to bring together researchers, healthcare workers, people that are doing things like behavioral economics, like how are people making decisions? How are our discoveries getting into the community, and how can we better implement them? And I wondered if you know of any places that are really trying to take the big picture view and try to get more of what we discover out into the world?
Well, there's, it's very complex, obviously, and I think there are two main frames. One is, how do we improve the translational science that allows interventions to be sanctioned, approved, or recognized and presented in the form of guidance or other clinically useful recommendations? That's one piece of it. And that translation does not always make it across the threshold. But then the other translation is, even if we know what to do, we're not doing it. And that is a part of our health system. It's part of our provider connectivity. It's a part of human nature to not change. If you've been doing things one way, why do something differently? But I think one of the opportunities we have now is the consumerism that Dr. Google, I would not want to be a patient of Dr. Google's, but occasionally Dr. Google does have some helpful perspectives to share. And I think the more we can get people to take ownership and to learn and to be confident in their ability to understand their health issues and the opportunities they have for improvement, we will have better opportunities to create a demand for the things that people need. But it's asking an awful lot for most people to be able to do that. And I think that's where patient organizations have come into their heyday now, to be really surrogate translators of health information. As chief patient officer at Merck, I've spent a lot of time with large and small patient organizations, and I've come to have enormous respect for their passion and sense of purpose, but also many of them now, of course, some are conducting their own research and funding things and have patents, et cetera, but some of them are more oriented toward just helping people navigate their health and their illness in effective ways. So, there's a huge gap there, but we do have some tools that could help us if they were applied for good purposes instead of some of the negative uses that we see all too often.
And just to follow up, I think that it was like what you mentioned, where, the commercial sector is not going to push everything forward. The researchers are not going to push everything forward, but you need some entity that can take a non-commercial view of what public health needs. And that's what I was sort of wondering, is if we can't push that agenda forward somehow.
Good question. Yeah.
Yeah, it's a great note to end on. Thank you, everybody, for the wonderful questions and for giving us your perspective, Dr. Gerberding. I'm going to hand it over to Professor Goldberg to finish the session.
Sorry, I was multitasking. I was starting another Zoom on my phone. That's how we roll here. Thank you, Claire, for moderating such a great session. Julie, thanks for everything you do for your alma mater. Good luck with your home renovations. It sounds like a really exciting project. And to all the med students and others who joined, and faculty, friends, and partners, this is a great session. Check our website for upcoming events. Only at the Veale Institute do you get TikTok on Wednesday and Julie Gerberding on a Thursday. So it's been a great week. Happy St. Patrick's Day, and see everybody soon.
Thank you.
Happy St. Patrick's Day, and thank you, Claire. Good job.
Thanks. Take care. Lovely.
Thanks, everybody.
Bye-bye.